Okay. So I think there's a lot of schedule confusion, so let's review this for everybody. It's my understanding that, let me go on a whiteboard and do this. It's my understanding that today we're 6 to 10, right? That's 4 hours. Tomorrow it's 12 to 3, and then 4 to 6. That's 5 hours is what I thought. And then on Monday, the following Monday, we got 6 to 10. That's 4. And then that Tuesday is 6 to 10. That's 4. So that's 4, 8, 12. It should be a total of 18, so that's 4, 8, 12. Then it's 4 to 7. Okay? So tomorrow it's 4 to 7 and 12 to 3. Okay, does everyone agree on the schedule? Okay. Not this Monday. I'm talking about the following Monday. Monday the 2nd, I believe, of March. We go back in March. Okay? So does everyone agree that tomorrow it's from 12 to 3 and 4 to 7? Excellent. All right, so let's get back to the class. Okay. Now this chapter, what do you think I'm going to tell you? This chapter is very, very, very high yield, okay? It's extremely high yield. So you definitely have to learn this chapter. So, hold on. This stuff you don't need to know. No, this chapter you don't need to know. I'm sorry. The new notes shouldn't have this chapter. Hold on. Let's go back. The new notes do not have this chapter. This chapter should be removed. I'm confused too. I'm sorry. Let's get rid of these notes. We have to do childhood disorders. This chapter, bad chapter. Go back. We don't need this chapter. Get rid of it. So let's get the next chapter, which is child psych. There we go. Let's see. Let's take a peek. Yeah. All right. Let's get some color in here. Now I can say this is going to be high yield. Okay, this one, the disorders. Okay, so we're all okay? All right, let's move on. So we're going to start out with mental retardation. Now, mental retardation is not called mental retardation in DSM-5. It's actually called, let me get to the text here. Let me write it in for you. Intellectual developmental disability. Doesn't that have a nicer tone to it? So intellectual disability or intellectual developmental disability is the new name for mental retardation in DSM-5. So technically, you could still see a question where MR is the diagnosis, but if you see something called intellectual developmental disability or intellectual disability disorder, that's the new name for it, okay? So the definition and the criteria have all stayed the same. So for you to have a diagnosis of intellectual disorder, what you need to have is an IQ that's below normal, and that means an IQ that's under 70. That's essential. The next thing that you need to have is that typically you are going to be below the age of 18. So you are young when you are being diagnosed with these disorders. And the next thing that you have is that you're going to have something called deficits in social adaptive functioning. Have you done peds yet? Pediatrics? No? Okay. So when you go over peds, I'm sure you'll go over mental retardation. Let me go to the whiteboard and let's review some things. So for kids who have MR, right, or the new word intellectual disability, right, are they detectable at birth? Yes or no? Is that true or is that false? The kids who have MR, are they detectable at birth? No, they're not. So we all agree on that, right? Good. Do they reach their milestones just like everybody else? Do the majority of them reach their milestones just like everybody else? Meaning sitting, walking, talking, standing up, running, social smile, the whole kit and caboodle. Do most of them reach it just like everybody else? Yeah, they do actually. So if you don't detect them at birth, you don't detect them when they're growing up, when do you detect them? The majority of them are going to be detected at school. When they start to follow, when they have to follow rules, when they have to take tests, when they have to listen to teachers, when they have to follow instructions, when they have to get along with their peers and do things as a group. That's when the deficits become apparent. And that is what is called the deficits in social adaptive functioning. Okay, that's what that is. So typically these are kids that are going to be detected in school. So it's in school age where you start to realize that Billy or Sally might have MR. So what are the risk factors for this? These are things that you'll probably go over in detail in pediatrics. Now, it could be born with these things. You could have had problems while the mom was pregnant. Maybe she got syphilis, maybe she got rubella, maybe she got some disease that affected the fetus, maybe she was exposed to certain toxins, or maybe she just didn't take her vitamins. Maybe she was in a home where she was beaten herself, or maybe after birth or during birth. What if you were born with the cord wrapped around your neck? Could that make you MR in the future? Could you have become infected with something that could have led to you developing this problem? Could you have eaten paint with lead and that made you MR? So the reasons are a lot. As a psychiatrist, they're not going to ask you the reasons. What we want to focus on in the psych questions is not going to be the whys, but what we're going to be focusing on is this. I want you to memorize this table. And there's one that is missing, which will be the profound. So I'm going to put a P here. P is for profound. You've got one missing. So that goes there. So what do you need to know? The 4 types of IQ ranges. You've got the mild, the moderate, the severe, and the profound. What is expected of you is that you know what is the level of functioning of each, what they can do, and what the IQ range is. So you need to memorize this because this is where the questions will come from. So what do we know about the mild? This is the biggest group. 85% of those that are retarded are mildly retarded. They do everything that we do, which means they go to work independently, they work independently, they live independently, they handle their own affairs, They do everything that we do. So basically, they have very little, if no supervision, from minimal to no supervision whatsoever. They're able to do whatever we do, okay? So they work, they handle their own affairs, and they live alone. Their IQs range from 50 to 70. The moderately retarded have IQs from 35 to 50. They reach up to a second grade level of education. These individuals need higher degree of supervision. So that means that they probably do not live alone. They probably do not work alone. They work in what's called a sheltered workshop, which is a supervised work setting. So they work, but they need a supervisor there watching to make sure that they're okay. The severely retarded have IQs from 20 to 35. You probably could teach them basic things like combing their hair, brushing your teeth, getting dressed in the morning. They don't benefit from vocational training, so they won't work. They don't work. They don't live alone. They don't make decisions. So they need a lot of supervision. And then you've got the profound individuals who basically do nothing. And they need to be in a highly supervised setting. You have to do everything for them because they're like babies and you're just going to have to do everything for them. So when you're looking, does everyone understand these four types? Okay, so when we diagnose MR, one way of doing it, of course, will be with an amnio. I know you did OBGYN, and I'm sure you went over amnios, when to get it, who to give it to, etc. So that's not a topic I covered. Understand that these things can be detected in amnio. How do we treat them? Well, the best treatment is to prevent it. So the way we prevent it is we want to make sure, let's say you've got a history of Downs in your family, you might need genetic counseling. You want to make sure that the women are living in a safe environment. You want to make sure that these women are taking their vitamins, being taken care of, etc. Okay? Any questions on MR? So what's important there is that you understand the types, what their functioning is, and how to differentiate one from the other. One thing that's important, let me go to the whiteboard, is that people who have problems with learning, let me get color, give me 1 second. Whenever learning is affected, what happens is that your self-esteem goes down, right? Everyone agrees. And what that does is that you tend to act out, right? So what does that mean? Imagine I'm 6 or 7 years old. You're the teacher. You send me to the front of the class because I have to read a little book. I don't know how to read. And when I start to read what I think are the words, you, as the other students, what are you going to do to me? You know kids are bad. You know they're evil. They're terrible. What will the other kids do to that poor little kid in the front of the class who obviously can't read or write or do whatever? They're going to laugh at him. They're going to call him names. They're going to tease him. How is that little kid going to feel about himself? Terrible. I don't like it. So what am I going to do? I'm going to compensate for it. So I might not be the brightest, but I will tell you, I'm going to punch you in the face if you laugh at me again. So you tend to see a lot of behavioral disturbances. I'm sorry, my mouse is going crazy. My battery's about to die. So you'll see a lot of these behavioral disturbances in kids who have learning problems. So kids who have MR can have behavioral disturbances. Kids who have learning disabilities can have behavioral disturbances. Kids who have ADHD can have behavioral disturbances. Does it mean that every kid who has MR, learning disability, or ADHD will have behavioral disturbances? No. What I want you to understand, it's something that can potentially happen. So can the MR be prone to violence because of this? Yes. But does it mean that all of them will be prone to violence? Of course, the answer to that is no. Does that make sense? Yes? All right. So let's move on. And let's get back to the class. Learning disorders, or the learning disabilities, are the kids who basically everything in their life is normal, except they have deficits in certain areas, and because of these deficits, it affects their functioning. And functioning, of course, when you're that little, is what? It's affecting your functioning in school. Because of your learning disabilities, your school grades are going to be poor, your academics are going to suffer. If you're older and you still have these learning disabilities, it's going to affect your work life. It's going to affect your life in general. There are 3 types of learning disabilities: reading, writing, and math. Reading, of course, being the most common one. So these are kids. Everything is okay with them except they have problems reading, writing, or adding and subtracting. What causes this? Who knows? There's lots of reasons, but a lot of them we have no idea what is going on. So it's much more common than MR. Remember, MR is seen in, let me go back because that's not in the slides. MR, we see it more in boys than in girls, right? And you're probably wondering what I'm doing, right? I'm like seeing things. So basically, it was a little fly that just drove by, listened to me. So MR is more boys than girls, and it affects about 1 to 2% of the population. Whereas learning disabilities is, oops, there we go, 5%, so it's a bigger percent. And these are also diagnosed in school just like the MR kids were. They can also have perceptual or motor problems. They tend to have school failure. They tend to have behavioral disturbances. Why? Because, again, of the learning deficits. So, also more frequent in boys, yes. And they also have low self-esteem, which you know leads to the behavioral problems. The way we diagnose is that we're going to do specific tests. They're not going to ask you this on the exam. What they're going to ask is either the diagnosis or the treatment. Okay? So when the kid has problems reading, writing, or adding and subtracting, and it's affecting their grades, then we can say it's a learning. Now, how do we treat it? Well, we're going to treat it by placing them in what's called special ed. And special ed is a different classroom. So you are removed. Let's say in the regular classroom, there's 20 students for 1 teacher. They put you in special ed where maybe there's 10 students to 1 teacher. So what does that mean? You get to spend more time with the teacher. The teacher gets to devote more time to you to help you improve your reading, your writing, your math, etc. The main focus of this classroom is to get you to improve your reading skills, math skills, etc. Okay? So basically, special ed, there's no pill for this. A pill's not going to make you smarter, but special education is what we'll do. What they do typically is if you're in special ed, you either stay there until you graduate or you get transitioned back into the regular classroom. Yeah, I wish a pill could make you smarter. Wouldn't that be awesome? Okay, let's talk about autism. I need to go to the whiteboard for this. Autism has had a lot of changes. So let me get the text. Be patient with me, please, because I need to write something. So there are several disorders that we're going to focus on. Autism, Asperger's, and Rett's. And today, everything is called the autism spectrum disorder. Okay. There was a disorder. It's like I'm telling you a bedtime story. Once upon a time, there was a disorder which was called pervasive developmental disorder. Pervasive developmental disorder. What does the word pervasive mean? What does pervasive mean? Like ongoing, right? Continuous. So these are individuals who had problems with one main thing. And the problem that these individuals had were problems with social connection. Their inability to connect socially was the problem. All of us connect with each other. Even in this medium, where I'm sitting in Florida, you're all over the country, where you see me, I don't see you, but we're still interacting because we've got a chat room. You are interacting with each other. You don't even know where you are. You're interacting with me. I'm interacting with you. That's because we have connected socially. We have the ability to connect. We look at people, we talk to people, we interact with people. The individuals that don't have that are in this cluster, which is called pervasive developmental disorders. In that cluster, in DSM-4, we had autism, we had Asperger's, we had Rett's. DSM-5 came along, removed all of these disorders, and now everything is called the autism spectrum disorder. So it lumped you all in one single category, and then it gave you specifiers as to the level of severity. So you either have very little loss of functioning or super duper loss of functioning, but everyone gets the same name. Okay? Does that make sense to everybody? Let's review. Yeah, this is mostly permanent. So what I'm going to do tonight is that I'm going to review autism. Then I'm going to go back to the slide and I'm going to differentiate how is autism different from Asperger's, different from Rett's. Everyone with me so far? All right, let's go back to the slides. So when we look at the main definition of autism and what it is, let me get some color out here. Give me 1 second. It's a disorder where you have problems with social interaction. Again, that's your inability to connect. Problems with communication, that's language. And this is the hallmark of autism. You have imaginative activities and interests. They really don't know what causes autism. There's lots of theory. Is it that the mother got rubella and that's what gave the kids autism? Is it the air? Is it the water? Is it a virus? Is it something else that's going on? We don't know. So there's no specific reason why one child would get autism versus another child. Typically, you make the diagnosis before the age of 3. You tend to see a lot more in boys than in girls. Autism patients have social symptoms. What are they? Well, let's go to the whiteboard. When we think of kids, right? The whiteboard. All right. When we think of kids and we think of social issues, right? What is it that kids do? Well, first of all, why are boys more affected? Because they think of the chromosomes. You've got the XY and that's why. So usually boys have more stuff than girls. So when we think of social issues, we know that children, when they're babies, they bond with their parents, right? So that when they finally bonded and the parents leave, then what do we call that anxiety? We call it separation anxiety, which means that the child will cry. That's a normal child. But yet, the children who have autism never bonded. So if you never bonded, what do you not have? You don't have separation anxiety. So when mommy leaves the room, what do you not do? Well, guess what? You don't cry. So that's one thing that's different. Kids who are normal want to be picked up by you, right? They have something called the anticipatory posture. If any of you have kids or nieces or nephews or godchildren, notice when you've got a child, whoa, what do? They look at you and they raise up their arms. What does this mean? Pick me up. I'm lazy. I don't want to walk. But that they want to be with you. They want you to carry them. Autistic children will never do that. Not that they don't have arms, like I'm making this person seem, but they just won't do it because they don't care about you. When children are hurt, what's the first thing that they do? They go to the parents, right? The parents then will kiss their boo-boo. The parents will give you that either Power Ranger, Band-Aid, or the Dora, or the whatever Band-Aid. You put the Band-Aid, you give them a little kiss in their boo-boo, and they're happy. They got attention. They got that nurturing from you. These are things that normal kids do. Well, guess what? The kids who have autism won't go to you when they get hurt. So what do? They soothe themselves. How do they soothe themselves? They rock back and forth. They bang their head against the wall. They bite themselves. They scratch themselves and things like that. So it's autism like having a cat? Oh my God. I don't have cats, so I wouldn't know. But I've heard that there's some friendly cats out there. So I don't know. So does this make sense to everybody? All right. So let's talk about the language issues. How are they having problems with language? Well, what do we know about kids? Kids say one word, right? Then they move on to 2 words, right? Then they move on to 3 words. Then they speak in sentences. Well, children who have autism don't do that. They don't develop language like normal kids do because their language is affected. So let's go back to the slides. They also have behavioral problems, behavioral symptoms. I told you they're very rigid. They're very inflexible. They cannot tolerate any change in the environment, any change in their schedule. How many of you saw the movie Rain Man? Now, that's an old movie, but how many of you have seen it? Noon, he had to watch Judge Wapner. Every Monday, he had to have pancakes. Every Tuesday, he had to have fish sticks. I don't know. And when you don't do that, when you disrupt their cycle or their way of doing things, they tend to act out. And that's very unique. They could be aggressive. They can bite other kids. They do weird things. They line up toys. They sniff toys. They love things that go around and around. So they might pick up a toy truck or a car and spin the wheel for hours and hours and hours. And these are the things that the kids who have these disorders can typically do. Most of them are mentally retarded. The lower the IQ, the greater the incidence of MR. A lot of them can have abnormal EEG, so therefore they can be prone to seizures. Let's continue. They can have self-injuries where they can bite themselves, they can scratch themselves. They've even been known to take their eyes out. And there's a rule of thirds. Remember, language is the best predictor of prognosis. So if their language gets better, their prognosis is better. So 1/3 of them do terrible, 1/3 of them do so-so, and 1/3 of them do okay. Okay, so that's autism. So when we're dealing with autism on the exam, you are going to get 2 types of questions. So let's go to a blank board. You will either get, give me a second here to get you some color, the treatment. They will either give you a kid who is autistic and aggressive, or they'll give you an autistic kid that's non-aggressive. If I have to make a bet, I'm going to tell you this is the one that they will probably do the most. Why? Because the non-aggressive kid, the treatment of choice will be behavioral modification. We want to improve their language. We want to improve their ability to interact with others. But if you have an aggressive, then the treatment will be, of course, the antipsychotic medications. And if they make you choose between old ones and new ones, remember, new ones are going to be the better answer. Why? Because they are cleaner. So the antipsychotics, like risperidone, olanzapine, haloperidol, those are the ones that we're doing. Is the antipsychotic treating the autism? No. The antipsychotic is treating the aggression. So if the autistic child bites, fights, slaps you, then you treat it with an antipsychotic. Okay? Does this make sense to everybody? Let's go back to the class slides. Do they have insight into their actions? No. They see that as being perfectly normal. They don't see it as having a problem. So the treatment, of course, is because it's affecting the family, everyone should be in their MR. You send them to special ed. And, of course, let me make this thicker. Hold on. Antipsychotic medications only if they're aggressive. Hearing impairment is a big differential. The way you differentiate someone that's deaf versus autism is that the deaf person will look at you, the autistic child will not. Eye contact is a way of communicating. So, so they tend not to look at you. Okay, now that we know what autism is, let's review, let's go back to the whiteboard and review the other things I put on here. Okay, so what do we know about autism? Let's review. We know that it's boys more than girls. We know that they have decreased IQ, and we know that their language is going to be impaired, okay? So they have problems with language, low IQ, boys more than girls. How is Asperger's different from autism? Well, this is also boys more than girls, so that doesn't make a difference. Here's the difference. Their IQ is normal, and their language is normal. That's how you tell them apart. They're about a child not responding to verbal commands. What is the major difference in a vignette that would suggest hearing impairment over autism? Usually they will mention something about whether the child looks at you, whether the child interacts with you. A deaf child will look at you and interact with you. The autistic child will not. Okay, so how many of you have seen the show Parenthood? The show Parenthood has a kid in there who's got Asperger's. It's a good show. Max in there has it. How many of you have seen The Big Bang Theory? Now, I know all of you. That's a very popular show. I don't think Sheldon necessarily has Asperger's, but I think it's probably the closest to Asperger that you will get. I'm not saying he has it, but he's kind of Asperger-like. Why do I say that? Because people who have Asperger's, they really don't have friends. And even though he does things with the other guys, he does it because he should. He doesn't get the jokes. He doesn't laugh like the others. He's very rigid. Wednesday is pizza night. Thursday is comic book store night. You can't sit in his chair. He doesn't connect even with his girlfriend. Even though he's changing, he doesn't even connect with his girlfriend. He has a friend that happens to be a girl. So he's kind of autistic, Asperger-like. Not autism, sorry. But he truly isn't, okay? Rets is different how? Rets is girls more than boys. They also have decreased IQ. They also have language problems, but they also have microcephaly, and they have this weird hand-wringing motion. Hand-wringing. kind of like that. Or putting their hands inside their mouth. Okay, that's Rett. So they'll give you a girl, they'll tell you all the characteristics of autism, but they'll tell you that the brain is shrunk and they have this weird hand-wringing movement. Then you call it Rett's disorder. All right? Usually all of these are going to be around before the age of 3. Asperger's might be a little bit later. And I don't know if you've been watching the news, but I think a couple of months ago they actually decided, or they learned, that they can actually detect autism in the first few months of life because whether or not a baby looks at you. So today, as I was telling you in my fairy tale, what used to be called pervasive developmental disorder with all these different types is now called autism spectrum disorder. So they could give you an autism question and the answer will be autism spectrum. They could give you an Asperger's and the answer will be autism spectrum disorder. It's just a matter of level of severity. Okay? So are we okay with autism and all that fun stuff? Okay. Let's move on. Let's go over ADHD, which is also high yield on the exam. So what do we need to know about ADHD? These are kids who are basically normal kids, except they have problems in certain areas, and these problems affect their functioning, and these problems are occurring in 2 or more situations. What are these problems? They have problems with attention, or they have problems with hyperactivity, or they have problems with impulsivity. And because of the problems, it's affecting their functioning. And it has to be in 2 or more scenario, meaning home, school, and work. So if you're very young, it's home. When you go to school, it's school. And when you're older and you're working, it's work. So typically 2 or more. That's why ADHD is usually diagnosed before the age of 7 because you're in school by then, and the symptoms have been lasting more than 6 months. Most of them are going to be diagnosed in school. You're going to see more of it in boys than girls. The majority of them, as they get older, their symptoms lessen. But about 1/3 of them will continue to have it even in adulthood. So what's important about kids who have ADHD is that when you look at the family history will be very similar. So what typically happens is that you have a kid who has ADHD, and because of the self-esteem and the learning issues, then they can have behavioral problems. If the behavioral problems get worse, and now they break the rules of society, then they get diagnosed with conduct disorder. Once you turn 18, then you're called the antisocial personality disorder. Now you drink, you use drugs, you have kids. What do you think happens? You go back, your kid has ADHD, behavioral problems, etc. By no means am I implying that every single kid who's got ADHD will become antisocial. This is the worst case scenario. Understand that this is something that could happen, not will happen. So how do we recognize these kids? Well, they can't sit still. They're fidgeting in their chair. They're accident prone. They push their way to the front of the line. Kids in school don't like them. Kids, the neighbors around the block, the kids don't like you because you can't follow rules. You can't follow instructions. You don't play nice. You suck the life out of the room where the teacher is constantly giving you attention and not anybody else. All right? So the question is, as far as diagnoses, IQ testing, they're really normal, so this isn't really going to be. There's scales that the teachers fill out and that the parents fill out, and that will give you, an idea of whether or not this child has attention deficit hyperactivity disorder. So what's important about ADHD is that you understand what on earth is causing it. They think, the theory is that these are kids that have decreased levels of norepinephrine, and these are kids that have decreased levels of dopamine. And these are the neurotransmitters that help with focus, concentration, etc. So when you give them drugs that raise these neurotransmitters, like the psychostimulants, then that's how you get better. So what the psychostimulants do is that they raise the norepi, raise the dopamine. So in a perfect world, excuse me, I'm sorry. In a perfect world, could I give behavioral mod techniques to improve a kid ADHD? Sure. I could make the class size smaller. I could give the kid more breaks. I could remove the class distractions, but realistically that doesn't happen. So typically the treatment of ADHD is to give them medication. What medications? The psychostimulants. Why? Because they help by helping you focus, helping you concentrate, etc. So there's various drugs. Let's go to the whiteboard because they're not on that slide. So when we're looking at the treatment of ADHD, there are two main types of treatment. The treatment will either be with a stimulant or a non-stimulant. Let's review these. Give me a second so I can write here. So I'm going to put something on the text box, okay? So give me a second here. What are the stimulants that I'm talking about? Well, we got methylphenidate, and we've got dextroamphetamine. Oops. The non-stimulants would be atomoxetine and guanfacine. Those are the types of drugs. No, the stimulants raise norepi as well. So methylphenidate and dextroamphetamine are both psychostimulants. Atomoxetine and guanfacine are what you call non-stimulants, and by that I mean technically they're like stimulants, but they don't give you the same side effects that the stimulants give you. So when we're thinking of side effects, what side effects are we talking about with these drugs? What kind of side effects? Let me go back to a text box. What kind of side effects do the classic stimulants give you? Well, they're going to give the kid insomnia, right? They're going to give the kid appetite suppression. They're going to give the kid maybe abuse, maybe addictive, right? Now, the non-stimulants have the same side effects, but less. And here's the beauty. Not addicting, so therefore no abuse potential. There we go. So as a parent, which one of these do you think you would prefer as a parent? And remember, we're looking at side effect profile, not efficacy. So as a parent, a lot of times you would prefer the non-stimulant. So how should these questions appear on the exam? A, you can get questions where they give you a case and you have to know the diagnoses. So they'll probably give you a boy. They'll tell you about problems at home. They'll tell you about problems in school. He can't sit still. He gets into everything. You know, how do kids normally sit in the chair or on the sofa, right? A normal kid would sit like this, correct? How do you think these ADHD kids sit? Like that. Or you've got the twirlers. They can't sit still. They can't walk from one room to the other. They do the ballerina approach. They're constantly twirling. They're constantly jumping up and down. That's what you find in these kids who have ADHD. So when we're talking about treatment, let's go over here. So the treatment question, if they give you a choice between A, which is methylphenidate, and B, atomoxetine, so they're giving you stimulant and non-stimulant. I want you to be very careful with the question. Go back to the question, and you'll probably see something in the question where they mention safetiness, I don't think is a word, where they mention safety, where they mention side effect profile, they mention parental concern. Something is pointing to one versus the other. So when safety is issue, side effect is the issue, parental concern is the issue, and both are mentioned, which one do you think is the better answer? Then the better answer is the non-stimulant. Does everyone agree? That's one type of question. Another type of question is where they tell you that they started on the stimulant. Because of that, the child has GI complaints, the child has lost 30 pounds. And then they want to know, what's the next step? Well, what do you think the next step is? You switch to what? You switch to the non-stimulant. Everyone agree? Exactly. Question number 3. You started with the non-stimulant. It's not working, plain and simple. The kid's still a mess. Then what do? You switch to the stimulant. So those are 3 possible scenarios. Another scenario is the following. These drugs work immediately. These drugs will take about a week to work. So the non-stimulant is not a drug that I can give you in the morning and an hour later the drug is working. That only happens with the stimulant. So what does that mean? For you to be on the non-stimulant, you've got to take the pill daily because it's got to reach a certain level in your bloodstream for it to be effective. So if the parent says to you, look, I want to give my kid a pill that I decide when he takes it. So tomorrow is teacher's work day. There's no school. I don't want to give him a pill that day. On the weekend, I don't want to give him the pill. Which one of these 2 would you recommend to that parent who wants to have that strict control of when to give it to the child? Stimulants are better. Why? Because they work that day, they're out of the system. You take it at 7 a.m., by 5 o'clock, it's gone. And the parents have that leeway. The non-stimulant, you should take it daily. One other thing that happens, typically in the summer, kids are taken off the meds. Why? Because parents don't want to keep you on meds during the summer. So what happens is towards the end of the summer, you need to make a decision. Does the kid still have these symptoms? If the kid still has the symptoms, put him back on the meds. If the kid does not, then you can take the meds away. Okay? Can you give the kids both the stimulus and the non-stimulus at the beginning until the non-stimulant gets into effect? I'm sure you could. But typically a week isn't that horrible to wait. But anything is possible. So do you have a clear picture of attention deficit hyperactivity disorder? Yes or no? All right. So why don't we go on our break here? And when we come back, we'll finish the chapter and we'll call it quits for the night. All right. Take care. See you in 10.